This is Health Yeah, your weekly update on what's going on in the health, wellness, and medical world with Monica Robbins.
Hey everyone, I'm Monica Robbins. Thank you so much for tuning into Health Yeah, your prescription for clear, concise medical health and wellness information. This episode is part 2 of a 3-part series on gender affirmation surgery, specifically phalloplasty, which is creating a penis using the skin of a patient's arm. In part 2, I talk with Dr. Gupta, a urologist with University Hospitals Cleveland Medical Center's LGBTQ Gender Care Services Clinic. He explains this complex surgery and the criteria needed for someone to become a candidate. Give me your history. How did you get into this?
Yeah, so I've been in practice for about 6 years. I finished my fellowship at Duke in 2014, and then went on to the University of Kentucky in Lexington, where I started the reconstructive urology and cancer survivorship program there. And the idea was that we were starting to offer services to cancer survivors that were not offered before to enhance their quality of life. And those services essentially required an amalgamation of various reconstructive techniques. And interestingly, those same techniques could be applied to taking care of transgender patients. So I had initially just patients started coming to me who had surgeries elsewhere and had complications related to them. Specifically, patients who had phalloplasties, so they would have fistulas or abnormal opening in the urinary tracts, or strictures or abnormal narrowing in the urinary tracts. And we would have the skill set to fix it. Over a period of time, it just made sense to just start doing the primary surgery ourselves, because as it is, we were taking care of the complications from surgeries that were done elsewhere. So truly an organic process, slow to start and gathered steam and momentum, because we had the right skill sets and the right idea. We just wanted to take care of the patients.
So then UH recruited you. Why?
So the reason UH recruited me was, again, a cascade of many events that came in and played a role. The urology department was undergoing a rejuvenation, as it were, and it was being expanded under new leadership. And my current boss, Lee Ponsky, was leading the charge, and he had the vision to see that university hospitals was not just not offering reconstructive urologic and cancer survivorship services, but also, it's one of those things, you don't know what you don't know. The gender affirming services were just not offered here. And no, it was not even on anyone's radar. It was almost a blind spot. And Dr. Ponsky had the vision to say, this is a huge need for our community. And he and I started talking at an annual Urologic Association meeting, where people meet less and drink more, to be frank. And we had several conversations leading up to 2 interviews that I did at university hospitals, during which I met the leadership at UH, including Dr. Simon, Dr. McGarrian, all of whom really reinforced my impression that UH was committed to embarking on a new era as it pertained to gender affirming care. So here I am.
How often do you see patients wanting, gender affirmation services?
Every day that I'm in clinic. So I'm in clinic 2 days a week, and every day I'll see at least 2 patients. Like last Monday, I saw 5 patients. So, but about 20% of the patients that I saw that day were wanting gender affirmation services.
I've done stories in the past on this, and what's so unique about phalloplasty is that, this is of the gender affirmation, this is far more difficult. Can you talk about, but there are options relating to this. Can you talk about this particular surgery and, why it was, I knew many people who had gone overseas to have this type of surgery and then came back and probably went to see you. What are the options? Because you don't have to go all the way, from the beginning. There are different levels of this type of surgery.
That's correct. Uh, Phalloplasty is arguably the holy grail of reconstruction as it comes to urology and plastic surgery. And basically what phalloplasty is just making a new penis. And it seems a lot easier than it is. We have to create a penis that looks like a penis, that works like a penis in that you can urinate through it, and then has other sexual effects, sexual characteristics or attributes of a penis. So the ability to have sensation, the ability to have erection, the ability to have orgasms. So there are a lot of functionalities in addition to just the anatomy part of it, and that's why it is so complicated. Typically the way it is done now, and this is something that has been the result of decades of research in it, the way it is done now in terms of the most accepted and the quote unquote the gold standard, as it were, is that we take a flap of tissue from a patient's forearm, generally the non-dominant forearm, so we'll take it from left hand for 90% of the people, left forearm for 90% of the people, and we use that tissue to make a urethra, the tube that men pee out of, as well as the outer penile tissue. And then over a course of about a year or so, we'll do more minor surgeries just to connect everything up, and then eventually put in a penile prosthesis or an implant to make sure they're able to have an erection and make sure they're able to engage in sexual activity. So yeah, it's a big deal. It's fraught with complications. It requires a high level of skill, patience, and ability to troubleshoot any untoward events that may happen. So that's that. There are other options that many patients choose to have short of phalloplasty. One of the more common ones that we hear about is metoidioplasty, which is really almost a neologism, that this word did not exist 25, 30 years ago. And it really means towards something. And this something in this case is the male appearance of the genitalia. In this, what we do is, instead of using tissue transfer techniques like making a penis out of the forearm, we just release some of the attachments of the enlarged clitoris. So the transmasculine men will have an enlarged clitoris due to the fact that they're on testosterone and other hormones. So we just release the attachments of the enlarged clitoris and make some, redo some tissue flaps locally and give the appearance of a small penis. Sometimes it is enough for men to urinate out of standing up, but yeah, sometimes that's even a struggle. But the biggest benefit of doing metoidioplasty is that it avoids the complications of phalloplasty. That's number one. But also it achieves the goals of a certain subset of patients. So certain patients don't necessarily want a penis when they look down. They just don't want to look down and see female genitalia. And all of it ties into the reason why we do these surgeries. We don't do these surgeries just because they're cool to do, they're awesome and great results. The reason why we do these surgeries is that these are the right thing for the patients. And the most important thing that most patients will say is they want to look down and not see anatomy that is inconsistent with their gender identity, excuse me. And a metoidioplasty is often enough to get rid of that misalignment and allow patients to have a consistent sense of who they are in terms of their gender.
Of your patients, of the percentage of patients you see, how many choose for full phalloplasty compared to pteroplasty?
I would say it's an evolving number, and the reason I don't want to pin a specific number. I mean, obviously, at the end of this answer, I will give you a specific number. But let me qualify this by saying that as we have gotten better with the services that we offer, all of that information diffuses around and people know about it. So 15 years ago, very few phalloplasties were being done at all because there were so many complication rates. And those numbers have consistently increased over time as physicians and surgeons have gotten better, especially as academic surgeons have begun to take interest in it, so we can critically perform these surgeries and evaluate these results. So right now, about 20% of my patients want a meteoroplasty and about 80% will want a phalloplasty, but that number is fluid. 5 years from now, it may be that 90% may want phalloplasty versus 10%.
How long does it take to do an entire phalloplasty? Because it's not just one surgery, obviously.
So the first surgery, stage 1, is the longest, and it takes us about 8 hours to do. And stage 2, which is 4 to 6 months later, takes about 2.5 hours. And stage 3, which is a year after the first surgery, takes about an hour. So yeah, the 8-hour operation is the big operation. It's almost like a symphony, because myself and the plastic surgeon, Dr. Toby Long, we are working simultaneously. One of us is working in the groin, the other one is working on the arm. Then we switch roles and we go back and forth toward the end, up until the end of the case. There is, we'll sometimes catch a little break in the middle when one is slightly faster than the other, and you can have a coffee break or something like that. But yeah, it's a long day for us. It's a long day for the patient. The reason we do it in a combined fashion is to play off each other's strengths and minimize each other's weaknesses. And I think we have had great results using that approach.
Can you talk about these particular patients and why a surgery such as this is so important?
Transgender individuals, some of the data suggests that they comprise about 0.6% of the population, 40,000 people within the state of Ohio. And this is just adults, not teenagers or children. So these are people who have diagnosed either gender dysphoria or gender incongruence. These people, these patients, these individuals are just like the rest of us. The only difference is that the sex that they were assigned at birth differs from their gender identity. And one can easily look at this with derision, sarcasm, or contempt, but it doesn't take a huge leap of faith or of compassion to empathize with what's going on. You can imagine someone looking down and seeing the things that that do not belong. Okay, so that's a little bit of a preface to it. That's a little bit of a prelude. But the idea is that we know that patients who are diagnosed with gender dysphoria have a misalignment of what the assigned sex was and what their gender identity is. We know that the seat of gender identity is complex, but it does not automatically reside in the external genitalia. We know that. So the third thing that we know is when a person has a misalignment in between the gender identity as well as the genitals, they have a terrible sense of distress. They have what we call gender dysphoria. They are extremely upset about it, to the fact that they cease to be productive members of society. They go in shells, they isolate themselves from their family members. And 40% of patients with gender dysphoria have thought about or attempted suicide. That's more than 10% the rate of the US adult population. Okay, so that's the scope of the problem. How do we address it? One way to address it is to beat into someone's head that, no, you're wrong. Think about, just look down and you see a penis, that means you're a man. Well, we know that doesn't work. This has been tried in different iterations over several hundred years. We know that conversion therapy doesn't work for gay individuals. In fact, it is brutal. I mean, it's to be condemned. Similarly, conversion therapy or some kind of psychotherapy to say, sorry about that, some kind of psychotherapy to say that we have to realign your identity such that it aligns with your external genitalia. That's the wrong approach. Okay. So with that in mind, then we can move on to how do we take care of the problem? How do we allow these patients to be productive members of the society. How do we allow these patients to to respect themselves and gain respect from their family members and their peers? And what we have found is an affirming way of approaching this entire issue, wherein um, we understand what the patient is saying. We provide them the services, be it mental health, be it counseling, be it hormonal treatment. And if the patient meets the criteria for gender dysphoria, which have been established through decades of research, then we can start them on the appropriate hormone therapy. We can start them on the appropriate surgical therapy. And guess what? When it happens, it's not just something that we are doing in a vacuum. When it happens and we go back and talk to these patients, they're much happier. They are secretaries, they are lawyers, they are our doctors, and they are taking care of us in many different ways. So it is, in my opinion, morally mandated to take care of these patients. It's a call to arms. And I'm glad with all the political things that have gone on over the last 5, 6, 7 years, I'm glad it gets the attention that it gets, because we definitely cannot. It is true that it's 0.6% of the population is transgender. It's a very small minority of the population, but it is also true that we'll be judged by the way we treat the most vulnerable amongst our population, and that is this population.
So for someone to qualify for this type of surgery, I would assume there's several things they have to go through protocol, correct? Can you kind of touch on what those things are?
Yeah, so we abide by the WPATH criteria, or World Professional Association of Transgender Health Standards of Care criteria. And what that means is any person who wants to have genital reconstruction, so either a vaginoplasty or a phalloplasty, must have met these criteria. That include that they must be living in the appropriate gender role for at least a year. So if they're a trans female, so they identify as a female, they must be living in the female role for at least a year. They must be on hormone therapy that is congruent with their identified gender for at least a year. So they should be on the estrogen therapy, for instance. And they must have 2 separate mental health officials attest to their diagnosis of gender dysphoria and attest to the fact that they are good candidates for surgery. And obviously they must meet medical criteria. They can't have terrible heart disease, terrible lung disease, and so on and so forth. So I mean, these criteria are pretty darn strict, and we really don't see anyone kind of slipping through the cracks in terms of getting the wrong surgery.
How many phalloplasties have you done in your career so far?
So we are probably at around the 35 to 40 mark. And I have done many more revision surgeries and people who've had surgeries elsewhere. But our program at UH is just picking up. Right now, we are doing about 2 phalloplasties a month for the next several months. So we're booked out for the next several months. Yeah.
This is not something covered by insurance, I would assume.
It is covered by insurance.
Really?
Yeah, yeah.
So all those people who went overseas had to pay out of pocket, and now they don't have to.
Correct. So I mean, there are certain exceptions, but and I don't want to bludgeon the timeline, but the idea is that some point in time, the last 5 years or so, CMS said that this should be something that should be, transgender care should be covered. And most insurances followed suit on it. Again, there are criteria for when they will cover it. There are certain aspects of the surgery that they still don't cover. So for instance, someone who's getting a breast augmentation or implants in the breast, that is not covered because that is generally not covered across the board. But gender affirmation surgery, for the most part, is covered. Insurances do make you have to jump through a lot of hoops, which we do. and try and do what's right for our patients.
How important is it now that UH has a program such as this?
I think it's phenomenal. I have always thought, going back, I don't consider that a platitude or a cliche. We have to take care of the most vulnerable among us. So for me, it was an easy moral calling. It was also fun because these are fun, challenging surgeries to do. So there's a lot of professional gratification and satisfaction out of it. But I think UH really has shown how aligned it is with the community, because this is something that the community needs and wants. And instead of saying, let us do, let's figure out what a bottom line would be in terms of compensation, money, and so on and so forth, they said, this is the right thing to do for our patients, for our community, and they invested in it. And it's UH is a beacon of hope in the state for this, for sure.
How many centers in the country do this particular type of surgery?
So there are many places that do either vaginoplasty or phalloplasty or different components of it. But I think fewer than 10 do the entire comprehensive, provide the entire umbrella of services that we provide, including top surgery, bottom surgery, vaginoplasty, phalloplasty. In terms of phalloplasty, there are a couple of centers. There's one center in New York, a couple in Miami, one in Chicago, Portland, San Francisco, and then Los Angeles. So, and I'm sure I'm missing, and a couple in Texas. So, probably about 10 to 12, I would think. The VA has, transgender healthcare. Unfortunately, they do not cover the surgical part of services. So, I've done phalloplasties, I think on 2 veterans, both of whom had to pay out of pocket because, it would not be covered. And it's a pretty hefty bill. And it's, the fact that these patients will borrow money, get a second mortgage, do whatever they can to get the surgery done, it only shows you how important it is to their sense of identity and livelihood.
Can you give me just a basic dollar figure? Because I remember when I did this story years ago, the individual who was trying to save up to get one was trying to save about $50,000. I assume it's much more expensive now.
Yeah. So having covered healthcare, how opaque the healthcare flow of money and finances are. Ballpark would be around $150,000 for phalloplasty. But I'm sure there are institutions that would say when they're cash pay, they would obviously charge a little less because that's
right.
That's the whole scam of healthcare. But anyway, and then I think the vaginoplasty cost would be around $30,000 to $50,000.
Is there a risk of it failing and not staying attached?
Yeah, so that risk is low. I mean, that essentially is what we call flap loss or flap necrosis, where the blood supply gets clotted off or something bad happens. And that risk is less than 1 in 30. So it's, as compared to other things like a hip replacement, it's still pretty high. But overall, in the scheme of things, it's less than 1 in 30. So less than 3% or so. Now, the risk of any bad thing happening, any complication happening is pretty high. And that risk is about 30 to 35%. So 1 in 3 chance that there will be a bump in the road. And the idea is that, everyone will have complications. The best phalloplasty surgeons have complications. I have complications. But the reason it is important that we are here is that we take care of the patients in our community. If someone has a surgery with us, they don't need to travel 12 hours to get that thing taken care of if they have a bump in the road. And that's the reason why we are bringing care to this community rather than being a quote unquote fancy, glamorized destination.
Please listen to part 3 of this podcast that focuses on the plastic surgery aspect of the phalloplasty procedure. Please find me on Twitter and Instagram at Monica Robbins. Catch up on health news and future podcasts on my Facebook page, Monica Robbins WKYC. Video podcasts are uploaded to my YouTube channel. Just search Monica Robbins and please subscribe too. Keep up to date on all of your news, sports, and weather on WKYC.com and the WKYC YouTube channel, and please follow the WKYC social media accounts as well. Random acts of kindness are good for your soul. Practice them daily. I'm Monica Robbins. Until next time, have a healthy week.
Thanks for listening to Health Yeah with Monica Robbins from WKYC Studios. Subscribe now so you never miss an update. And find more on everything you heard here on WKYC.com and on the WKYC app.